we start with this talk, and this topic particularly is very close to my heart because patient journeys is something, we sit behind a screen, we report scans, but the interaction with patients when we do while we're doing the ultrasound or maybe some fluoroscopy guided procedures or biopsies, etc. And that is when you learn more about the patient and the impact that we make as a radiologist or as a non-vascular intervention radiologist. So I think that was my intention of presenting through this talk, as in what happens to a patient at not a particular time of point, but what their journey is going through some of the difficult pediatric malignancies, and neuroblastoma is top of the list, one of the most commonest extracranial solid tumor in children. Okay, so let me get started. So this is just a brief overview of what we have in the UK, and this is more or less quite similar from the incidents, quite similar in other regions of the world. So after leukemias and brain tumors, soft tissue sarcomas tops the list of pediatric malignancies, followed by neuroblastoma. Um, so the common presentation of any abdominal mass in children is usually, there will be a lump or a swelling felt by the parent while giving them bath or putting cream, etc. And the other less common presentations are in very young child. They may present with failure to thrive, or they might have something very non-specific like constipation, vomiting. Sometimes it can be purely incidental, and they might present with metastatic deposit, and that could be the primary presentation. And as we go through some of the cases, we will come across some of the common presentations. So when we think of an abdominal tumor, the most important part that we as a radiologist should think of, like where is the location or the site of origin. The second thing that should come to our mind is, okay, now we have located where the lesion is. Now we should think of what is the tumor type. Is it benign, is it malignant, something which needs doing something going forward, like a biopsy or referral to an oncologist, or it is something which you should leave alone, like maybe a lymphatic malformation or a vascular lesion, which you definitely don't want to biopsy. So if we'll once we know that, okay, this is a tumor, and then we need to properly describe it in our report, then we should think of what is the stage or what is the grade of the tumor. And that now depends on various factors like size, what is the extent, is there any vascular involvement, what is the lymph node status, and what is the metastatic status. The next step that comes in the molecular biology. So once we find the tumor, they undergo some sort of intervention, usually a biopsy, and then we have the molecular biology. And putting everything together, we get to a proper risk grade or a stage. On the basis of that, the further management is decided, be it leave it alone, chemotherapy, radiotherapy, surgery, etc. There's a very good article in radiographics in the last quarter of of the year, which it's more like a practical guide and what things you should consider for various abdominal tumors. So I think this is one which you should pick up if you're interested in pediatric abdominal tumors, which gives you a very good overview of it. Okay, now let's look at childhood neuroblastoma as a whole entity. So um, when we talk about childhood neuroblastoma, there are various factors involved. One is the origin. Where is it originating from? So it's usually the neural crest cells. So at the time of closure of the neural tube, the last process of closure of the neural tube, that's when the neural crest cells detach, and they are usually a transient type of cells, which later on evolve into different cell types. So we will go through it now. Talking about neuroblastoma as a whole, we need to also think of what the tumor microenvironment is, on the basis of which the treatment depends, and how do we diagnose, and what the current treatment recommendations are. So we'll go through some of it as we talk about neuroblastoma further. Now, this is just to show you um, what type of uh, neural crest cells, which are the ones which are important from the point of view of neuroblastoma. So the neural crest cell derivatives, they undergo evolution, finally forming sympathetic ganglion cells and also forming part of the adrenal medullary cells. So when we look at this chart of fetal adrenal gland, then there are so many different types of cells, of which the medullary cells form a very small component compared to the cortex. And when we look at just the medullary cells, there are again various different types of cells that we are looking at, and one of them is the late neuroblast or the cycling neuroblast. These are the ones which have more propensity. So then when we look at what is the conception period during which they are most active, so if we just concentrate on the purple area there, so that is around 17 weeks. So that is when, if there are some amplification factors which are involved, that is when, the congenital variant of neuroblastoma picks up, and that is when it starts developing. So you might see some of the congenital neuroblastomas even on the antenatal scans. Um, Okay, so that was just a brief overview of the development part. And like I said, neuroblastomas mainly develop from the neural crest cells. It is one of the most common extracranial tumor in children, and the most common site is the adrenals. Um, that makes abdomen as the most common site of neuroblastoma. And amongst the other sites where they can occur, from the skull base all the way down along the paraspinal region. Okay. Imaging wise, neuroblastoma is a very heterogeneous mass. It can have necrosis, and calcification is usually present most of the times. That is one of the feature which goes more in favor of neuroblastoma. When we are looking at an abdominal mass, we are not sure where it is arising from or which compartment it is in. Neuroblastoma, like I said, because it arises either from the adrenal or from the parasympathetic ganglion cells. It doesn't occur from a major organ as such, which has a very thick capsule around it. So that is why, the cells, they can rapidly grow, and as they spread out, as the mass is growing and spreading out, it tends to encase the vessels. Also, not only that, but also because it is slightly more aggressive compared to the other abdominal tumors, like for example Wilms tumor, which pushes the vessels rather than encasing them. Similarly, neuroblastoma can also invade the adjacent organs and can sometimes present as a renal mass because it has completely invaded the kidney, for example. So from the imaging point of view, ultrasound always is the first imaging modality, isn't it? When we think of an abdominal mass or a query abdominal mass, that's how they present. And you do the ultrasound scan, you see a mass lesion. It's a challenging situation when you want to discuss the findings with the parents. But ultrasound is usually the first modality, but the modality of choice nowadays is MRI. Um, MIBG is undoubtedly one of the most useful nuclear medicine scan, which tells you more about the metabolic side and the activity side of the lesion. So MIBG is usually, now the recommendation which is coming out is MIBG should be performed with a spectral, a SPECT CT on presentation, as well as for staging and for response assessment as well. So both imaging by CT MRI or an MIBG go hand in hand. So we have to look at it as a whole picture. In UK, the pediatric radiologists, if I'm looking at a case of neuroblastoma and I'm presenting in a multidisciplinary team meeting, then I would be reporting their, I would be probably doing the ultrasound, doing their reporting their MRI scan, doing the staging, and also report their nuclear medicine scan. So, it's a complete holistic approach uh, from the MDT point of view. Some of the odd presentations of neuroblastoma are with an opsoclonus myoclonus system, which is a very typical rhythmic germic movements, or sometimes very rarely they can present with something like a profuse diarrhea. Okay, so let's look at a case of neuroblastoma. So this is a 15-month-old boy limping for the past 2 days, and the general practitioner noted there was some right hip swelling. So they referred them for further evaluation. Especially, there was no history of trauma. So hip swelling without a history of trauma is a red flag. And so they were referred to a pediatrician. Pediatrician examined properly, and they found the abdomen was quite distended with a probably hard to form mass. So they referred them for an ultrasound. Ultrasound shows this typical hypochondral region mass lesion, um, appearing quite heterogeneous echogenicity with some echogenic areas, some possible necrotic areas, possible areas of calcification, quite large. Now here we can see it's not very diffusely infiltrating, but there's lots going on the middle aspect of the lesion. So this is the axial view where you can see bits of the liver, and then you can see the spinal vertebrae as well. And this is the longitudinal or the sagittal view. Okay, so we did their MRI scan, and then this is a T2 space sequence where I've done some marking for the structures. So as we're going through, you see a large mass lesion in the right suprarenal region. The kidney is pushed inferiorly, and if we go back to the lesion, um, we can appreciate that the liver is pushed quite significantly as well. The IVC is near completely encased, and it is compressed as well. We can see the right renal vein, and we can see the kidney separate from the lesion. So it's the kidney surface is scalloping, but still it is seen separate from the lesion. Other than that, we are seeing a lot of lymph nodes in the background, and on the MRI, there's lots more to appreciate. You can also look at the bones if there are any bony lesions, especially in the spinal vertebrae. Okay, so on diffusion weighted imaging, the lesion showed quite significant restricted diffusion. And we did an MIBG because this was very obviously a neuroblastoma. So on the MIBG, you can see there's increased uptake in this region. And then this is the excretion in the bladder, and that's the tracer going out into the diaper. So that's the skull part, that's the body part. Here are the limbs, and here are the lower limbs. So you can see some uptake, abnormal uptake here in the right proximal femoral region. So if we go back to this coronal sequence and try to see if we can figure out the right proximal femoral region, so it will be right at the edge of the screen, and you can see this abnormal soft tissue there in the right femoral proximal femoral region. So the proximal femur is involved, so there's a bone metastasis. Okay. Um, so normally on an MIBG, what we would see is normal uptake in the submandibular, in the salivary glands, normal uptake in the myocardium, normal uptake in the liver, and sometimes you might see uptake in the renal excretory system and urinary bladder. So normally we don't see this large uptake which we are seeing in the right abdomen. We don't see this uptake in the bones at all. So the bones should look somewhat like this. So loss of normal physiological uptake is again an indirect sign of increased uptake elsewhere. Okay, so this patient underwent biopsy, and they have they had some amplification of MENK, and we will go through it. Also, the segmental chromosomal abnormalities and ULK mutation. So these are some of the biological features that are very important from grading or the risk category grading for this patient, and on the basis of which the treatment is decided. So we'll come to that after this case is discussed. So let's go back to the case. So on follow-up imaging in September 22, we saw that we could see some normal physiological uptake in the liver, in the salivary glands, in the bladder, etc. The bony uptake had largely gone, which was there in the right proximal femur. The abnormal uptake, large soft tissue there, had mostly gone. So they had shown some good response to treatment. And the lesion had significantly reduced in size. So this was purely on the basis of chemotherapy. And you can see the lesion has gone down to one third or less than one third the size of the original tumor. But what we are still seeing here is measured on this T2 axial image is this area of soft tissue around the IVC. So that's the IVC. We are seeing some soft tissue around there. And then you see the right kidney, the top of it is still involved. If we look at it further down, then you can see there's an obvious difference in the appearance of the renal capsule on the right compared to the left side. So normally you don't see the renal capsule as such, but on the right side you can see the thin hypointense rim. That means the kidney is involved and the capsule is definitely thickened. So it will be very difficult on the operating table to separate out this lesion from the right kidney. Here you can appreciate it even better. So when they're planning the surgery, that means they have to do a right nephrectomy as well, which is not very uncommon in cases of suprarenal neuroblastomas. Many of the patients, they end up with a nephrectomy with the lesion excision as well. From the staging point of view and the preoperative assessment point of view, what is important to look at is if it is encasing any major vessel. So we are seeing that there is a significant encasement of the IVC on both sides. There's probably a lymph node, but you can see the wall quite irregular. And even on the other side, you can see that there is some distortion of the caliber of the IVC as it's going down. So these are the red flags on imaging. Now, these were raised, but um, the patient underwent surgery, and intraoperatively, even on the surgery, they found that the right kidney was involved. The lesion was extending higher up towards the diaphragm, and the tumor was adherent to the IVC with no clear plane of excision. So what they did is they tried to look at it all around the IVC, and they could not find a proper plane of separating out this lesion. So even if they would want to resect it from the operative point of view, it would be a blind resection which risks damage to the IVC. And on the basis of all those pluses and minuses of surgery, they decided to not take out the lesion. Um, so imaging plays a very important part in that scenario. Now, for the follow-up imaging from September 22 to Jan 23, this lesion, residual lesion is still there, and you can see it. They underwent a high-risk neuroblastoma chemotherapy followed by stem cell transplant. By November, they were asymptomatic, keeping quite well. Now, this lesion, the residual lesions, many times the neuroblastomas are not completely excised. There will be some residue. Over time they undergo the tissue becomes dead, it undergoes fibrosis and mostly calcification. So we might still see a large soft tissue in the abdomen, but that does not necessarily mean that is active disease. But unfortunately in this case, because biologically, a molecular analysis showed that they were quite high risk with MINC amplification and the chromosomal aberrations. They are at a high risk of recurrence, and that's what happened. From November 23 to March 24, they had a large recurrence in the upper abdomen, and then eventually it became quite widespread in just 2 months, and the patient did not survive the recurrence in this particular case. Okay, so debulking in the first part was not possible, and it is again, like I said, not very uncommon for the aggressive varieties of neuroblastoma. Okay, so what is important for us as a radiologist to understand? What should we be doing in our reporting to help the most to the operating surgeon, to the oncologist, to the radiotherapist, is to properly stage them. And for neuroblastoma is the International Neuroblastoma Group Staging System. where L1 is loco-regional and IDRFs means image-defined risk factors. So for every body part, there are different IDRFs for neuroblastoma, and this is just an example to show you the mainly the abdominal IDRFs. So it's not always possible to remember all the IDRFs by heart. So we always keep a chart handy to refer to when we are reporting such a complex case to see if there is any encasement of any major vessels or there is intraspinal extension or infiltration of adjacent organs. So these are the image defined risk factors, and this put them into higher category, and the surgeon is aware what they are going to expect on the operating table. Stage MS is a special category in very young children less than 18 months of age. So if they have an abdominal tumor with the metastatic disease confined to the skin, liver, or bone marrow, then that means that they would be categorized as stage MS and may not necessarily be into the high risk category. So a bone metastasis versus a bone marrow involvement in neuroblastoma, they are two separate things. And this is what I understood very well when I joined the SIOPEN or the SIOP neuroblastoma group, and we had a big discussion on this. So in neuroblastoma, you can have bone marrow involvement, which is basically involvement of the developing stem cells, or you can have a bone marrow, or you can have a bone metastasis where the bone cortex actually is involved with a soft tissue component to it. So these are two different things. Okay, so from the oncologist point of view, once we grade these lesions into a particular stage on imaging, now based on the grading, the age of the patient, then the type of the tissue on biology, and if they are having any MINC status or chromosomal aberrations. So considering all of that, they are put into different categories. So they can be low risk, intermediate risk, high risk, or very high risk. And like I said, MINC amplification itself, even though it is an L1 disease, puts them into a high risk category. So there is no metastasis, there's not much of lymph node involvement, but then because they are MINC amplified, they go into a high risk category. Okay, so let's look at the treatment part of it. So if we look at how to prognosticate neuroblastoma from the tumor stage at presentation, so less than 18 months of age is something which is favorable for the patient, and they're less aggressive, they have better prognosis compared to when the kid at presentation is more than 18 months of age. But keep in mind that the median age for presentation is 19 months, so it's almost at the borderline of the prognostic category. The tumor oncogenes that are in that we should be aware of are the MINC amplification. Now, at presentation, when we're looking at the first scan, this is not very important because we might not know the status. Of course, they are not biopsied by then. But then when we are doing the preoperative assessment or the follow-up assessment, especially end of treatment scan or further follow-up scans, knowing the molecular variations for this particular tumor is very important, because then we need to raise the index of suspicion, especially if they are MINC amplified. And it is not an uncommon occurrence for neuroblastoma, which occurs in about 20% of all neuroblastoma cases and 40% of all the high-risk groups. The reason being the MINC amplified tumors, they have higher resistance to chemo and radiotherapy. Okay, and the other markers like we have seen on the risk category charting is the type of DNA structure and some exogenic variants like ULK mutation. So this is just a risk chart to show you what happens when they're MINC amplified versus non-amplified. So this is the risk scoring versus MINC amplification. So if they're amplified, they go into a higher risk category compared to the non-amplified variety. Similarly, if they're more than 18 months, they again go into a higher risk category. And this is based on the surgical staging. Okay. So we have there are other chromosomal aberrations to look at, so we can skip this bit. So the treatment part is based on the risk group, low risk, intermediate, or high risk. They can be treated with just observation if they are low risk and less than 18 months of age. And usually the congenital varieties, they undergo no treatment, even though they might be a bit chunky in size. And I will show you some examples. Whereas the intermediate risk, they usually undergo chemotherapy followed by resection, and the high risk, they usually undergo induction chemotherapy, surgical resection, followed by stem cell transplant and radiation, and some antibody treatments. So the high risk category, especially with the abnormal oncogenes and MINC status, they have to undergo quite a larger treatment period compared to the low risk and the intermediate risk. And that's what I was talking about. So this is a chart showing the treatment for the high risk group. Okay, so the high risk group treatment depends, again, like I said, on the tumor microenvironment. And then there are some immunotherapy approaches which are very useful nowadays, and one of them is a CAR T cell therapy. So this is something which you might come across in the referral. And every particular treatment type is associated with their own complications. So it is very important to have a look at the whole picture rather than just focusing on the tumor. Okay. So since I'm part of the SIOPEN committee, we are going to come up with some recommendations, and these are some of them. So I'll just quickly go through some of them where MRI DWI is now coming up in some smaller studies as of additional value for detecting small metastatic lesions, for tumor heterogeneity, and to assess response to treatment. So let's say, for example, on the presentation scan, their ADC value was quite low, let's say 0.4, the average ADC of the tumor, whereas on further follow-up assessment, the lesion has not reduced in size, but the ADC value has increased from 0.4 to, let's say, 0.6 or 0.7, which says that there is inherent internal change in the tumor type, in the tumor microenvironment, and it has shown some response to treatment by the way of the imaging biomarker, which is DWI, even though they have not reduced that much in size. So that is a very good way of assessing the tumor. So pediatric abdominal tumors, may not necessarily follow the racist guidelines to the T, and these imaging biomarkers are very helpful in those situations. We are also going to recommend a whole body MRI along with MIBG, especially useful for the MIBG negative disease. The other recommendations that image-defined risk factors should definitely be reported. There is a scoring system on MIBG, which is the SIOPEN scoring system that can be used, or the QD-CORI system that can be used as well. But scoring should be performed for the nuclear medicine scans. And for the preoperative assessment, there is still an argument where the UK counterparts thinks the MRI is enough, whereas some of the European countries, they feel that contrast enhanced CT is also quite useful for preoperative assessment. And for possible residual tumor, it has to be MRI. Okay, so let me show you some cases now. So this is case one, where you can see that there is a soft tissue lesion here adjacent to the right kidney. So this is an extra-adrenal lesion. The mean ADC is 0.7, 0.8 nearly. So this was seen congenitally at birth, and they had raised catecholamines. So because they are small in size, they're not invading any structures, this was a very low grade stage. And usually for congenital neuroblastoma, smaller lesions, the strategy is to observe with monthly ultrasound and urine analysis. And by the time of 6 months follow-up examination, the lesion had regressed completely. So this was only observation, no treatment given for this case. Let's look at another case. So bilateral adrenal neuroblastomas. Now looking at this picture, we initially thought, is this congenital adrenal hyperplasia? Because neuroblastoma, you would expect it to be more like a mass lesion, and it didn't show much of restricted diffusion as well, but this was a bit atypical. They had a liver mets and the urine catecholamines were positive. So again, um, uh, you know, they were just um, because there was discrepancy on the imaging not completely fitting with neuroblastoma. This was biopsied and confirmed as adrenal neuroblastomas. And the biopsy showed that the Ming status was negative, and um, uh, they were low risk. They were stage MS because there was liver metastasis. Remember, stage MS is skin, liver, or bone marrow mets go into low risk, go into stage MS, which puts them into a low risk category. So they were just observed, and this is the 6 months follow up. So that's the liver, right adrenal, spleen, left adrenal, returned back to nearly normal size. And I remember this kid very well, following them up every few months, and they had a good outcome overall without any treatment. Okay, now let's look at case 3, where we saw a slightly larger lesion, and that was on presentation. This was also seen antenatally. So this measured about 3.5 centimeters with raised urine catecholamines. So again, they were low risk. They were observed. 1 month follow-up. They were more or less quite similar in size. 3 months follow-up, they appeared smaller. By 7 months, they had nearly gone. So there was complete resolution by 7 months, just by observation. Again, showing that we might not have to treat all the neuroblastomas. Okay, now this particular case where you see a large lesion on the presentation CT scan. So this was again a congenital left adrenal neuroblastoma. They were MINC negative. The plan was no treatment and just observe, even though they were quite huge in size, and MIBG was positive. By the age of 7 months, they had a visit to Paris where they were seen by an oncologist. They were seen, gone to the hospital for some other reason, and they were seen by an oncologist. On follow-up assessment, it had been growing small, but still the oncologist there suggested surgery to take it out. They came, we thought, we had a different thought. We just followed them up, and it had quite significantly reduced in size. But because it was also associated with something which was affecting the patient's growth, a decision was taken to operate it. So because it was partially encasing the SMA and the aorta, a part of it was left behind. And so this was at 3 years follow-up post-surgery. And on the latest follow-up scan, we still see the soft tissue there, but there's no activity in it. And the lesion has been stable over 9 years of time. So we can sometimes have a chunky soft tissue still remaining in the abdomen, but that might not necessarily cause any significant symptoms. That might not necessarily reflect active disease. Okay. And another case, so this is a classic neuroblastoma presentation, large mass, partly calcified, encasing a lot of vessels. You see the aorta is uplifted. MIBG, other than the large uptake in the lesion, you see a lot of skeletal uptake, almost like a super scan appearance. And this is the follow-up where you see where you see just the normal physiological uptake, little bit of residual uptake in the lesion. Okay, so let's look at this case in detail. So on presentation, they presented with limping query osteomyelitis. So they did a pelvic MRI, and we found this large metastasis, multiple metastasis in the bone. You see how abnormal the marrow looks, and a lot of and a large soft tissue, which even on the chest X-ray you could see this large calcified area. Okay, now the lesion is encasing the vessels. There is a thrombus in the left-sided IVC. And MIBG was positive. Okay, so they also had extensive mets, but just on follow-up at 1 year, significant improvement. The lesion had contracted significantly in size. So they showed excellent response to chemotherapy, and they were MINC negative with no chromosomal aberrations. So it, um, the MINC status, chromosomal aberration status, plays a major role in this tumor type. There were some unusual presentations, like this 3-year-old from Iran was diagnosed with multiple bone lesions, and CT MR head was done as patient presented with skull swelling. And you see the soft tissue mass lesion on either side of the skull with some spiculated kind of a pattern. The bone is diffusely infiltrated over there. And this is again one of the differential pattern for skull lesions or skull-based lesions, where you see the spiculated kind of a periostal reaction. Now, a close differential to this, there will be some differentials like Ewing's, etc. LCH will look very different. You might not see periostal reaction, but you might see some bone destruction, sclerosis pattern. So in this particular case, we did the whole body MR, and the whole body MR showed no mass lesion along the sympathetic chain or involving the adrenals. And the skull lesion was biopsied. We had seen multiple metastasis in almost all the bones. Even on the X-ray, you could see this abnormal involvement of the bone over there. Okay, so MIBG was done, which again showed this super scan-like appearance where there's no loss of normal physiological uptake, extensive metastatic disease. Um, and Skull was biopsied, they were non-amplified, ALK negative, and no chromosomal abnormalities. So in 3 months of chemotherapy, that's the response. What you're seeing now is normal physiological uptake. So that's right, that's left. So on this view, you're seeing uptake in the liver, in the myocardium, normal salivary glands, and the urinary bladder. So excellent response to treatment in just 3 months. This is another case where the kid had congenital hyperinsulinism, and that's why they underwent F-DOPA PET CT scan. Now, F-DOPA is another emerging tracer which is coming as an alternative to FDG PET scan in neuroblastoma, especially the MIBG negative disease. So this is just to show you the activity of F-DOPA that was picked up incidentally diagnosed lesion in the right suprarenal region. And we did further assessment on ultrasound and MR, where it was showing restricted diffusion, and overall the lesion was then excised, and there was overall good outcome for this patient. Okay. So that was this case. Familial neuroblastoma is another class where nearly 1% of neuroblastomas are familial, rest most of it are sporadic. Now, let me take you to the story of this kid. This was a 3-year-old who presented with thoracic and abdominal masses, and you can see this large mass lesion in the left upper chest along the mediastinal reflections. And then you see this large soft tissue, mainly in the retroperitoneum along the iliac chain. So neuroblastomas showing uptake on the MIBG scan in that area. Okay, so this was sibling one, and they presented when they were 3-year-old, and the mom was around 7 months pregnant at that time when this kid had the first presentation. And the second sibling was born while the first sibling was under treatment. And around at 9 months of age, on screening, we found they had some thoracic and abdominal lesions as well. So here you can see this extra-adrenal lesion on the middle, near the hilum of the left kidney, some thoracic lesions as well, which show activity on MIBG. So this was neuroblastoma as well. 2 siblings. Okay, now let's look at sibling two. So this is their presentation scan. They had chemotherapy and resection of all the lesions. Till date, they have no recurrence. They're doing really well. So this is their latest imaging from September 24. We don't see any abnormal soft tissue, no abnormal marrow activity. Okay, let's look at sibling one. Sibling one, who presented with large lesions in 2017. The thoracic one was excised. Of course, the abdominal could not be. They were ULK and MINC negative, but they had some chromosomal aberrations. In 2020, they had good response and were completely in remission. But in 2022, they relapsed, and then you can see this large lesion involving the rib, and then a small lesion there as well. Um, Unfortunately, in a couple of years, in spite of aggressive treatment, they progressed. There were multiple bone metastases. There were some soft tissue lesions coming up as well. And then they had large further recurrence, and they had ascites, significant ascites associated with the tumor progression. So I remember this case very well. Sometimes, symptomatic treatment, we do ascitic tapping. So I was in the operation theater, put in a drain, and there was frank hemorrhage coming out of the drain. So then we had to clamp the drain, call the oncologist, and discuss like what should we do. This is frank hemorrhage, the ascitic, and there's no trauma to any vessel or any organ. This is straight. It's pretty straightforward. You see such a large collection in the abdomen, you put in a drain, um, you get frank hemorrhage. So then the discussion is, should we put leave it on draining or intermittent draining, or should we take the drain out? As if we take out a large amount of blood from the abdominal cavity, they might not survive, etc. So intermittent draining was done, followed by multiple transfusions, but then they had bouts of hematemesis, so they were going into failure overall, and they did not survive the progressive episode. So this was the siblings. The second sibling is doing really well, but the first sibling did not survive. Okay, so what are the learning points coming to the end of the talk? Um, Early presentation, they generally have a better prognosis. Understanding the molecular and genetic landscape of neuroblastoma is absolutely important if you are into this field, or if you are interested to be going into pediatric radiology and doing oncology work. DWI is coming up now as a great bioimaging marker, especially to talk about the tumor heterogeneity or the tumor type at the presentation scan, then for staging and response assessment. High resolution imaging is absolutely necessary for surgical planning. Like I showed you in some of the cases, we're doing a study on that at present, assessing utility of T2 space or the high resolution T2 sequence, especially for the suprarenal lesions. Um, it is important to align your imaging protocols with the SIOP guidance. So look out for a paper which will be coming out in a few months with the recommendations of what imaging protocol should be. And above all, I think it's very important to have compassion for the patient and the family, because it is something which no one expects, and it's a big toll not only on the patient but for the family and friends. Okay, I would end my talk there, and happy to take any questions.